Hello and welcome to my channel. Today we have to discuss a very important topic, which is non-motor symptoms in Parkinson's disease. We are going to talk specifically about depression, anxiety, apathy, which is lack of motivation, pain, and some sleep issues that you see in patients with Parkinson's disease. Let's start defining what is motor and non-motor symptoms. The motor symptoms are the symptoms that you are able to see. They are very easy to identify. Why? Because are visible. You can see them, right? So this lady with a right resting tremor, this is typical for Parkinson. This patient also have bradykinesia, which is a requirement to say that somebody has Parkinsonism in the setting of Parkinson's disease. Bradykinesia means a slow movement. So all those motor symptoms are easily to identify. Now, the non-motor symptoms are usually more difficult to identify. They are actually referred as the hidden face of Parkinson. Many times, patients don't want to talk about it. And interestingly, 50% of the patients fail to report those symptoms to the provider. Now, if you see this graphic here, you can see that those symptoms, non-motor symptoms such as constipation, RVD, which means REM sleep behavior disorder, which is acting out during sleep, decreased sense of smell, and depression and daytime sleepiness, they might start many years before motor symptoms onset. So you see 0 here is when the motor symptoms, the tremors, bradykinesia, the rigidity start. So you see that constipation might start even 20 years before. Remember, that doesn't mean that everybody with constipation will develop Parkinson's disease, but you see these kind of things. For example, you see somebody who out of the blue at age 65 start having depression or severe anxiety without any reason. Something is cooking. And that might be a sign of initial non-motor symptoms in Parkinson's disease. Now, this article, very nice article published in 2020 in Neurology, the Green Journal, show that even though that the slow movement and the stiffness are the most common and uncontrolled Parkinson's disease symptoms, they are not the symptoms that really affect the quality of life of patients. And this is an online survey of more than 600 patients. So they found that the symptoms that really affect the quality of life are this one that you see here: confusion, memory loss, depression, anxiety. These three are the most common. Hallucinations, pain, and fatigue. And they affect more the quality of life of patients when compared to the tremors, the stiffness, and the slow movement. So this is important to discuss. Now, let's talk now about how you can tell if somebody has clinical depression, if somebody has major depression, right? Remember that depression is defined in, there are many terms and many type of depression, minor, major. There is something that we call dysthymia that now they call it a different way. I'm not going to talk about that. I just want you to be able to identify what symptoms can make you think that the patient has depression, so you can tell your provider, so you can identify those symptoms in your loved one, right? And you can tell the provider, listen, I think he's having depression. And then they will take over, right? That's the most important thing. Now, here I'm not I'm not talking about the normal reaction that you might have when somebody die. So when somebody die, we all are humans, so we feel sad. If you have a dog like this dog, 11 years old, she passed away, right? I was not expecting that, and you will feel sad. But I had the capacity to adapt and to move on, right? So you feel sad, but you move on. Now, I'm talking about major depression here, major depression. So these are the characteristics that I want you to learn so you can identify. Now, patients with major depression, and this is based on what we call, this is a big, huge book of psychiatry, is DSM-5, which was published in 2013, but they made some modifications in 2022. So these two first symptoms are very important. You need to have one of those symptoms. You need to be sad and with a depressed mood or loss of pleasure, okay? Loss of pleasure. Now, in addition to this one of these two, you need to have 5 more of this. I'm sorry, 4 more of this. So in total 5, but one of them have to be this one, or depressed mood, or loss of pleasure. So recurrent thought of death, change in your sleep pattern, reduced energy, persistent change in appetite. So it could be you're eating too much, gaining weight, or losing weight. Okay. Problem with concentration and difficulty with memory. So these are the symptoms. So if you identify any of those symptoms, then you need to tell your provider. However, do you see something here? That these last 5 symptoms are extremely common in Parkinson's disease, and you don't need to have depressed to have reduced energy, difficulty with memory, problem with concentration. So that's why sometimes it's very difficult to make the diagnosis of depression in patients with Parkinson. Might be challenging. And this is why many years ago, a group of experts in Parkinson changed the criteria and modify the criteria to make the diagnosis of depression in the setting of Parkinson easier. Okay, so increase the sensitivity. Because remember, if you don't treat depression, your quality of life will get affected significantly. And this is one of the things that not only affect the quality of life of the patient who is suffering from Parkinson, also the spouse, the family, the caregiver. Apathy and depression are the worst symptoms in patients with Parkinson when we talk about what really affect the caregivers. The apathy, and we will talk about apathy soon. Now, let me go to the next slide. So how you treat depression, and this is the most important thing because this is what you really want to know. Now, so we always start with non-pharmacological treatment. Remember, not everything in medicine is a pill. You need to do other stuff, right? Exercises, you know what I'm going to say about exercises. There's no question about it. Exercises work in almost everything, you name it. But this is the data. This is the data in patients with Parkinson. So this is what I would recommend. Yoga. Yes, I know yoga might be boring. But we have evidence that yoga might help in the setting of Parkinson's disease, and specifically in depression, improve the quality of life of patients with depression and Parkinson's disease. We have data to prove that. Now, there is something very important, which is talking therapy. When I say talking therapy, I mean cognitive behavioral therapy. What is that? This is a type of therapy that teaches you to modify what you are thinking, what are in your thought, so you can behave better, right? So patients with depression and anxiety, they have something that we call self-defeating thought. So basically, it's just they're very negative. So if you think that you are going to fail in something, you will fail. So the talking therapy or cognitive behavioral therapy teach you how to change your state of mind, because remember, your body will follow your state of mind. The problem with this is to find somebody who can be an expert on this, okay? So there is a bunch of websites, just Google it, just Google who is certified in cognitive behavioral therapy in your area, and if your insurance cover this. And don't feel bad about getting the therapy and you don't fit with the therapist. Just go and you try your best. You might need to change the therapy, you change your therapy, because if you don't have the chemistry with the therapist, this is not going to work. Okay, so that's the problem with this, finding the correct therapist that fit with you. Otherwise, it's not going to work. Actually, can make things worse. Acupuncture is another one, very safe. Might be expensive, but just check. Massage therapy, pretty good, and we have evidence too. Now, if we talk about pills, medication to treat depression, well, the first choice should be, and this is based on evidence, in patients with Parkinson, should be Effexor, or what we call venlafaxine. So it should be the first choice. Venlafaxine, I typically start with a low dose of 37.5 in the morning, because if you take it too late, it might cause insomnia in some patients. So even though that is a long-acting medication, but I believe if you take it in the morning, would be better. And then after 1 week, you keep increasing by 37.5 milligrams, and to reach doses of over 150. And some patients actually respond to a low dose of even 75 in the morning, especially we are talking about depression. Patients with anxiety might require a little bit higher doses. Now, the other medication with some evidence in the setting of Parkinson's disease and depression, I'm talking about depression, right, is this medication, pramiprazole, okay? Pramiprazole. There is some evidence that also might help. Pramiprazole, I start with a tiny dose of 0.125 milligram daily. And then I increase every 3 days, every 4 days, and sometimes every week. And sometimes you might need the medication 3 times a day, twice a day. Now, remember, the other medication I want you to pay attention is this one here that we have here, paroxetine. Paroxetine is a medication that I don't like to use in patients with Parkinson over 65. Why? Because it has some anticholinergic effect, right? So if you ask me which of the SSRIs, right? SSRIs are medication that increase the level of serotonin inside your brain. So paroxetine is the one that might cause cognitive issue. You don't want that. You don't want that. So because paroxetine have some anticholinergic effect, and also it might cause orthostatic hypotension in some patient and weight gain as well. So which one is the one that causes more weight gain here is paroxetine. So that's why I don't like to use this medication, very old medication. Now, if you ask me again, and I will have a slide about which one is my favorite one, is Effexor, definitely Effexor. And also I use sometimes duloxetine, which is Cymbalta. We'll talk about that soon. Now, if you are spouse, if you are daughter, the son, caregiver, what can you do? Well, the most important step is you to be able to identify depression symptoms identify depression symptoms, which, like I showed you in prior slides, is not just feeling sad. There are many other things. Okay, so you need to be able to identify so you can tell the doctor, the provider about those symptoms so we can have an action, we can do something about it. Because typically patients with Parkinson, they don't complain too much. I don't understand exactly why they don't complain too much. Probably because something related with the dopamine. There is something that we call Parkinson personality that they don't complain. So when they actually complain about something, this is pretty bad. Okay, so that's in general. Now, this is very important that you as a caregiver, you need to take care of yourself. Because if you don't take care of yourself, things are not going to work well. Imagine that you are in a plane and the plane is crashing, right? And from the ceiling, you have the oxygen. So why they teach you is just you put your oxygen first. The same thing happened with Parkinson. You need to treat you need to take care of yourself first before taking care of your loved one. Because if you don't feel well, things are not going to work well. Very important that you as a caregiver take care of yourself. Now let's change gears here and let's talk about a little bit about anxiety. I want to say first that anxiety is something very important that we need to survive. And in order to perform well, you need a little bit of anxiety. The problem is when the anxiety crosses the line. There is a line, imaginary line. So when you have a important activity, for example, a big presentation, or you have a race, you feel, or you have a fight, you're going to fight a boxing match, right? So you feel anxious. But those people that perform very well, the level of anxiety is a good level. So enough to improve performance. The problem is when the anxiety, like I say, cross the line and it start affecting your life. That's the problem. And this is the type of anxiety I'm talking about. When the anxiety affects your function, your daily activity. Again, a little bit of anxiety, good to perform well. Okay, so when you see people in a competition that they don't feel anxious at all, they feel like nothing, that might not be good. You need a little bit of anxiety to push you. Okay, so now the pathological anxiety in the setting of Parkinson's disease, there are many types of anxiety, but let's talk about the most important one in the setting of Parkinson's disease. The most common one is general anxiety disorder. We call that GAD. But we also have a panic disorder, which is a panic attack. Okay, very bad. Social phobia, very common thing that happens in people with Parkinson. Okay, we don't know if this is just part of the disease that they feel like that, and that's why many times they don't want to be in public, either because they feel embarrassed about the tremors and how they look. So that happened a lot. And one of the most important one is the anxiety related with the off phenomenon. So when the symptoms of Parkinson are present. For example, usually that happens in the morning when you are off medication for a long period of time. Your brain tell you, give me my levodopa or I will make you very anxious. So there are many ways for the brain to tell you, give me my levodopa, give me my dopaminergic medication. Otherwise, I can make you anxious or I can squeeze your legs. I can give you pain too. So we'll talk about pain soon. So, and that's the type of anxiety that many of the psychiatrists fail, because if you don't have experience with patients with Parkinson, you will miss this type of anxiety. And then you will treat the patient with the incorrect medication. You think that the patient needs SSRI like Lexapro or Zoloft, but the patient just need to modify the dopaminergic agent, maybe need a extra dose of levodopa, cinnamon, retarded at night, or something else to increase dopamine, right? So, and that's the problem, that when you deal with depression and anxiety, the expert tend to be a psychiatrist. However, not every psychiatrist have the experience to deal with patients with motor fluctuation in Parkinson's disease. So if it's difficult to find a general psychiatrist right now, at least in East Tennessee and probably in the whole US, it is going to be more difficult to find somebody with experience in patients with Parkinson's disease because the management is different. The same thing apply with patients with Parkinson. The blood pressure in patients with Parkinson, the management is totally different. Well, I don't want to say totally different, but significantly different. Why? Because those patients with Parkinson, many of them, they have what we call autonomic dysfunction. So there is a system in your body that control your internal organs. So your pulse, your blood pressure, your temperature, sweating. So this system in many patients with Parkinson doesn't work well. So which means that we cannot follow the typical guidelines that we use in the general population. So that's why you need, as a provider, to understand how this works in patients with Parkinson. Now, let's talk about what is anxiety, and in this case, general anxiety disorder. So you need these two: excessive worry about negative outcomes or events. You keep worrying about things, Inability to stop thinking about it. You keep thinking about the same thing. And remember, you need to have functional impairment. Otherwise, we can now call that generalized anxiety disorder. And you need to have three of these symptoms, at least three of them. Okay, for 6 months, and everything for 6 months. So you need to have sleep problem, insomnia. In this case, insomnia. You are restless, becoming reactive. So somebody tell you something and you react like crazy. It's just you are very irritable. Fatigue, muscle tension. You feel tense, difficulty concentrating. So you need three of these in order to say that the patient has general anxiety disorder, in addition to these two. Okay? This is how you make the diagnosis of GAD. How do you treat those patients? What you can do? Again, non-pharmacological management first, right? Non-pharmacological management first. And this is the evidence. This is what we have available in the setting of Parkinson. And the evidence in anxiety, for many reasons, there's no good evidence in patients with Parkinson and anxiety. There's a lack of randomized controlled trial. But this is what we have. Acupuncture might help, and you see the reference here. Okay, acupuncture might help in the setting of anxiety. Again, cognitive behavioral therapy, very good for anxiety. The problem is, again, to find a good therapist. That's the problem. Music, relaxation, massage, all this stuff help because release the emotional stress. Yoga, Tai Chi, anything combining your movement, slow movement with breathing and meditation, all these things help to make the muscle more relaxed and make you feel better from the anxiety standpoint. And the other thing that I always recommend is walking. You need to walk, not just for your body, but also for not only for your body, your heart, for your brain, for your emotion, the way that you feel. Walking is just amazing. You just do it. And it might sound boring, but just go outside in the morning, treadmill, unless if it's in a treadmill and you have a TV, otherwise it would be very boring. I understand that. So, but if you can walk. How much? Well, you can start even with 5 minutes, and every week you increase progressively. So you need to push yourself a little bit, right? So start slow, and you don't need to walk every day, at least in the beginning. You just walk every other day, but you need to have a schedule, a structure. So if it's at 9 a.m., it's at 9 a.m. Don't change that no matter what, unless you are sick, right? But that's very important. Now, this is my recommendation, okay? And this is based on evidence and my experience taking care of patients for many years. This is what I would recommend for you if you have depression, anxiety in the setting of Parkinson's disease, okay? Check this. So, number one, make sure that you wake up and go to bed at the same time every single day. You cannot mess with this, okay? This is what we call sleep hygiene. You go to the bed at the same time, wake up at the same time. 10 p.m., you go to bed at 10 p.m. and you wake up at 6 a.m., no matter what, okay? You try your best to do that. Sleep is a big deal. People, if you cannot sleep well, you will become very, very irritable. You will become anxious and even depressed. There is a strong association between not sleeping well and depression, okay? and sometimes you don't know which one is first, right? If it's the depression of the sleeping issues, is the chicken or the eggs. But definitely there is a correlation there, okay? Walking again, walking. In the morning, I prefer in the morning because in the morning is you have more energy. It's better to do it and keep your energy level high when you do it in the morning, okay? Don't do walking or any type of exercises 3 hours before going to bed. Otherwise, you will have issues sleeping. And that's why in the morning is better. Yoga and Tai Chi. Try to combine mind or body meditation. That's the best thing that you can do to treat your anxiety and depression. And it's good for your joints and your mobility in general. So it's good. This one is very important. And is pet therapy. I prefer dogs. So I have been having dogs since I was a little kid. So I don't see myself without having a dog. I have two. So dogs, for reasons that I cannot explain, I don't know, help you a lot with anxiety and depression. It's just give you a motivation that you need to get better. You need to move on in things because there are many people, dogs that depend on you. So having a dog, it just pushes you a lot. And dogs are always happy to see you, always happy to see you. So it's just a connection. Now, if we talk about medication and you ask me which medication is my favorite in the setting of Parkinson, and anxiety and depression, right? So I like to use Effexor because the evidence that we have, venlafaxine, but also I use Cymbalta. Cymbalta is duloxetine is pretty effective as well. And remember, the good thing about treating depression and anxiety in patients with Parkinson, they respond. Usually they respond pretty well because maybe, and I say maybe, because we are not completely sure about that, right? There is no way to measure how much serotonin you have in your brain directly. Indirectly, you can. We believe that there is a deficiency in chemicals in the brain. And that's why when you give those medications and you compare with placebo, so giving the patient a sugar, you see improvement. So that's why medications in the setting of Parkinson and depression work pretty well. And people tolerate the medication pretty well. But these are my two favorite medications because it works in norepinephrine and serotonin, the Effexor and Cymbalta. Now, sometimes I use Zoloft or escitalopram, which is Lexapro, these two. Zoloft, in my opinion, And based on experience, using these two medications, I believe Zoloft, I think, is better for anxiety. I cannot prove that, but this is my experience. I see Zoloft better for anxiety when I compare with Lexapro. However, take more time to work when compared to Lexapro. In terms of tolerance, all of them, people tolerate the medication pretty well. All of them, they might give you GI side effect, especially Zoloft might give you diarrhea in some patients. But people tolerate the medication pretty well. Now, let's see. Now, how do you treat apathy? And when I say apathy, I mean lack of motivation. What is that? And how common is that? Well, I will tell you that this very, very common. The thing is, patients don't complain about that. Do you know who are complaining about that? Caregivers, the family, the daughter, the son is complaining about that. The apathy drive them crazy. Okay, the lack of motivation, because this is a patient who used to do everything, who used to do always interested in golf, always interested in going to Florida, and now the patient will tell you, I don't want to go, you stay. So that's the type of problem that actually drive the caregiver crazy, because it's just so difficult to deal with. And the problem is difficult to treat. Okay. Now, and you might say, but apathy could be also related with depression. Yes, you're right, but not always. There are many patients that they just have this attitude that I don't care, and they don't feel depressed. They just have this sensation that I don't care. And why that happened, we don't know, but could be related with the dopamine pathway and maybe serotonin pathway. But interestingly, those patients with significant apathy, this is highly associated with cognitive decline, so cognition decline. So, and that's why sometimes we use, and I will show you soon, this medication, which is the medication that we use for memory issues, for cognitive issues in patients with Parkinson, but also we have evidence that might help in patients with apathy. I'm talking about Exelon or rivastigmine. But before going to medications, always better to try non-pharmacological treatment, right? Always non-pharmacological treatment. And the first thing is to provide the patient with a consistent daily routine. Remember what I say about Parkinson and actually everybody should have a routine of things, otherwise things doesn't work well. At least in my case, I have a routine of everything. Otherwise, things, it's just living like that doesn't work for me. But in Parkinson, it's more important. And people with Parkinson need a push. When I say a push, I mean somebody who can tell, listen, let's go. Don't even ask, just take them, let's walk. Don't ask, do you want to walk? No, 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 no. Let's walk. It's 9 a.m. It's time to walk. Let's walk. We have to do it. Okay. Now, also, some people join a support group of Parkinson. That might help in terms of the lack of motivation. So there are many things that you can do, but this is one of the things that I always recommend. Now, let's change gears again here and let's talk about a very important topic in Parkinson that many times we don't discuss. Why? Because people think that this is nothing related with Parkinson, okay? I don't need to tell my Parkinson doctor about my pain. Well, guess what? Pain is a very common non-motor symptom in Parkinson, okay? Either because it's part of the condition or because, remember, Parkinson is very common in elderly. So you get older, you have more pain. So years ago, I don't have, now I have knee pain, hip pain. But when I was a teenager, I don't have any pain. So because I'm getting older. But in people with Parkinson, it's more common. pain is more common than the general population. And that's why it's very important to talk about this, because we have treatment. And let's divide this in different type of pain, okay? Let's talk about this one, which is, I believe, is the most common one, which is a musculoskeletal pain, muscle, bone pain, muscle and bone pain. So this is common in the general population, but more common in patients with Parkinson. And that might be related to many factors, like I mentioned before. Stiffness. Remember that one of the motor symptoms in Parkinson is having stiffness, rigidity. So one of the initial symptoms, especially in young onset of Parkinson, females, I don't know why, females, they have frozen shoulder. So they have unilateral shoulder pain. So when you see somebody having significant shoulder issues, only the shoulder, check for rigidity. Check for rigidity at the level of the wrist, at the level of the elbow, because it might be a sign of Parkinson. Okay? Very important. Now, what can we do? Because this is what you care the most. Okay? So treatment, number one, exercises. You know what I'm going to say about exercises. But which one? Well, if you have a issue with muscle pain, musculoskeletal pain, try to see a physical therapist. A good physical therapist will help you with that. They are trained for that. And now to be a physical therapist, you need to have a doctor degree. So they are actually doctors now. So exercises. And yoga, tai chi, all these type of exercises, you name it. But I would strongly recommend, if you have pain, get a professional opinion from physical therapy, especially if you have Parkinson's disease. Okay. Now this is a medication that is shown based on some data that it might help with pain. Okay, I don't prescribe this medication too much because it's too expensive. And actually, I can tell you that I don't think I have any patient with on this medication, but the evidence is there, and you can see the article here, okay? You can see the article here. So it might help. And this is what we call MAO type B inhibitor, okay? Similar to salengeline, similar to Acilect, very similar, but it have a little bit of another type of mechanism of action with work with glutamate, which is another chemical in the brain. Anyway, very expensive medication, but if you have pain, you have Parkinson, this is a medication to try. Deep brain stimulation, there is some evidence, and you see the evidence here, that patient with pain, especially it could be also central pain or even musculoskeletal pain, like we are discussing now, deep brain stimulation might help. So I have seen patients, because they are less rigid, and the medication, the symptoms are very well controlled on deep brain stimulation, and the pain get better. So something to think about it. I never promise the patient that the pain will get better when you get deep brain stimulation. No, I will say the pain might get better, okay? Because there is some evidence, but not in every patient. Remember, every patient is unique. Steroid injection, specifically, make sure that the doctor who is going to do that, the provider, usually is a pain management anesthesiologist, or could be a neurologist fellowship trained in pain management. So they need to know anatomy very well to inject in the correct place. Otherwise, it's not going to do anything. Acetaminophen or Tylenol. So you can take, actually, it's very safe to take no more than 2 grams of Tylenol daily if you are elderly. So if you are over 65, it's safe. And you can take 500 every 6 hours, and that might help with the pain. It's safe. Again, venlafaxine and duloxetine is actually for pain, and duloxetine Cymbalta is approved by FDA for musculoskeletal pain. Venlafaxine will be off-label, but it's similar, the same mechanism of action as duloxetine. So this is two medications that you can use, especially if you have depression. Especially if you have depression or anxiety, this is the medication that I will use. These two medications, venlafaxine and duloxetine. Trigger point injection, this is very easy to perform, very, very, very easy, and very safe, very safe. Could be even dry needle, so dry, so without anything. Just when you perform this when you introduce the needle, that enough release the muscle, cause the spasm like get better when you perforate the trigger point. But many times we use lidocaine or we use a little bit of steroids too. But many times just dry needle will be enough. Now, if you have too much dyskinesia, which is a Michael J. Fox type of movement, this is how I describe to patients so they can understand. It's a dancing like of movement, right? Sometimes that exacerbate your musculoskeletal pain, arthritic pain. So what you have to do is just to have a better control of your dyskinesia. So you have to modify the way that you use levodopa or amantadine trial. Now, there is another type of pain which tend to be very painful. That happen usually in the morning, but not always. And when happen in the morning, most likely is a off phenomenon. For example, if you are one of those patients that say, doctor, at 6 a.m. when I wake up, oh my God, I have this, it's like a contraction of my legs. My cough is just like tightness, and it's always almost at the same time. It's at 6 a.m. in the morning. And then when I take them after 1 hour of taking my medication, my carbidopa levodopa goes away. So that's a dystonic pain. Dystonia means abnormal posturing. Think about dystonia like the muscles are contracting in the incorrect way. So the agonist and antagonist and the coagonist are contracting, and this is why you have this torsion of the movement and these spasms. Okay, so but that happens many times when you are off, when the medications are out of your system, when your levodopa is out of your system. So the brain is telling you, give me my levodopa, or I will squeeze you, right? And this is what happened, dystonic pain. Or sometimes the brain, like I say before, give me my levodopa or I will make you very anxious, okay? There are sometimes, or many times, these type of pain happen without any relationship with levodopa. It just can happen at 5 p.m., 6 a.m., it doesn't matter. So you still can manipulate the carbidopa levodopa. You try, and you can try with using, for example, if this is happening in the morning, you can try the CR, the control release formulation at bedtime, or if you have in Brija, which is the inhaled levodopa, you can use it, or even the patch, the rotigotine patch, you can use it. It might help. But if changing or adding dopaminergic agents doesn't help, then you need to try botulinum toxin injection when it's local, when it's, for example, left leg, because these tend to be effective. The only thing is that you need to find a doctor who knows anatomy and can understand where to put the needle. Otherwise, it's not going to do anything. So remember, all this procedure, you need to find a doctor who can put the needle in the correct muscle. Otherwise, it's not going to do anything. And some patients, unfortunately, doesn't work well, even though that you think that you are putting the medication, the Botox, the Xeomin, the Dysport in the correct place, and sometimes it doesn't work. Okay, but you always try because it's very safe. Botulinum toxin is very, very, very safe. Now, this is another type of pain, and it's a nerve pain, a neuropathic pain, and it could be when you have a root, and we call that radicular pain. So you have a compression. It could be because you are compressing a nerve or a root of the nerve, right? And the treatment when you have a structural lesion is surgery, right? So sometimes you need surgery to remove whatever is compressing the nerve, okay? And this is why you need an expert in surgery, which typically is a orthopedic surgeon, to take a look of your imaging study, and they do a good exam and they have a plan. Now, you always need to check for common things that might cause nerve pain or neuropathy, right? So common things are prediabetes or diabetes. This is very common. Just having prediabetes predisposes you to have nerve pain, and you need to have a good control of your glucose. The other thing is vitamin B12. So make sure that you have a vitamin B12 level check and should be over 400. Otherwise, you might need a replacement. So many times we don't find the cause. Why I have nerve pain? I don't know. So many times we don't know. I will tell you approximately 25% of the time we don't know, and we call that idiopathic. Idiopathic means I don't know. It's a fancy word to tell you that I don't know. Okay? Idiopathic. So then you try medication to calm down their nerves. And everything depends on what you have, what other condition do you have around you, right? Because if you have a patient with depression or fibromyalgia, which is another condition, you might need Cymbalta, duloxetine, or venlafaxine, right? So it depends what every patient is different. But otherwise, I like to use Lyrica or pregabalin. People tolerate the medication pretty well. The main side effect of pregabalin and gabapentin, which is the sister, is sedation. And you need to adjust based on renal kidney function. Remember that. Now, steroid injection, again, it has to be performed by somebody who knows anatomy very well. Otherwise, it's just like injecting water, like nothing. Now, let's talk about sleep disorder in Parkinson. That's the last thing that we will talk. REM sleep behavior disorder. What is that? So remember that REM sleep behavior disorder is very common in Parkinson. Approximately 50 to 60% of the patient with Parkinson disease, they have REM, rapid eye movement sleep behavior disorder, which is acting out during sleep. So those patients, you are supposed to be paralyzed. When you are sleeping in this specific stage of sleep, we call that REM, you are supposed to be paralyzed. The only muscle that is working or moving during this stage is the diaphragm, okay? The diaphragm, the muscle of the breathing, that's the only one. The other muscle should be paralyzed. We call that atonia. So people with Parkinson, this system doesn't work well. So they are acting out their dreams, and not actually a good dream. They're not pleasant dreams. They are very bad dreams, like nightmares. So they're punching, kicking, moving a lot, screaming. So very bad dreams, very common. So the management basically is, number one, again, you try to minimize medication that might be associated with this problem. For example, stopping or decreasing. You never stop those medications. You taper down. Remember, you never cold turkey. You don't do that. Otherwise, you have a withdrawal. It could be very bad withdrawal. Okay, so remember, those medications, you do not stop cold turkey. You taper down, and obviously under the supervision of a physician. Okay. So you try to decrease your Lexapro, your Zoloft, your Cymbalta, which is a SNRIs, SSRIs, I mean Lexapro, Zoloft, there are many. And beta blockers like propranolol. So beta blockers that penetrate the blood-brain barrier So we have a wall in the brain, and propranolol penetrate that. So those beta blockers also might exacerbate RVD or REM sleep behavior disorder. In severe cases, you might need to put some mattress on the floor next to the bed, or even at bed rails, because people fall from the bed. And then I have seen patients having trauma, hip fractures, and even punching the wall and having fractured the hand. Okay, and the patient can hit the partner too. And they are having the dream, and there's a vivid dream. Okay, I see these all the time. So when safety is an issue, that's a severe case. Okay, and you need to treat those patients. So the first choice is, because in terms of safety, the only side effect that you might have with high doses of melatonin is the first choice, is probably GI side effects. Okay, GI side nausea, feeling sick, nauseated. But otherwise, people tolerate melatonin pretty well. But the key here is you have to take it at the same time every day. This is not PRN thing or as needed. It's at 8 p.m., like 2 hours before bedtime. Okay, 2 hours before bedtime, take your melatonin. I always start with 5. I might go to 10. Okay. I will tell you my experience, no more than 50% of the patient will improve with melatonin, but I always try. I always try. Now, clonazepam is the most effective. Clonazepam work very well. However, you have side effects. You have side effects, and you can watch my video about what are the side effects of benzodiazepine, including clonazepam. I have a YouTube video explaining that. But just to summarize, it might not be a good idea if you have significant cognitive issues. And the problem is that people with significant REM sleep behavior disorder, they also have some cognitive issues. So that's why you have to be careful with the clonazepam and try to keep the lowest dose possible. I don't know, I can count. If I have a patient over 2 milligrams, it's because somebody started before, and we are not being able to decrease. But otherwise, I keep the doses in 0.5, 1, 0.5, 1 at night. And one important detail is that make sure that you do not have sleep apnea, because if you have a sleep apnea and you are not getting the treatment for sleep apnea with typically the CPAP, the sleep apnea will get worse with clonazepam. Okay, just relax the muscle here. So you will be snoring more and more apnea. So you will stop breathing more at night when with these medications. Okay, so be careful with that. Now, another thing is sleep fragmentation, insomnia. So people with Parkinson, they don't have too much issues falling asleep. They have issues staying asleep. They have issues staying asleep, and you need to rule out secondary causes. Okay, like the regular a patient without Parkinson. So things that predispose you to wake up is, imagine that you have overactive bladder. You need to wake up 4 times, 6 times, and some patient even 10 times at night to pee. So what's going to happen? You're not going to sleep well. So you need to give medication to calm down the bladder. Otherwise, you are not going to sleep well. You might say, "Oh yeah, I go back to sleep quickly." Yeah, that doesn't work like that. So you might think that. So what is normal? So more than 2. When you get older, your bladder doesn't work well. So you might realize that when you turn 50, you go once, and that's normal. Twice, that's normal. I would say more than 2. Going to the bathroom to urinate might be abnormal, and you see that in patients with Parkinson, and we have medication to treat that. Now, always avoid fluid, water. When I say fluid, I mean water. In the morning, try to minimize later in the day, during the afternoon, but otherwise, your bladder will get full, and you need to go to the bathroom to pee more frequent, okay? That's common sense. Medication side effects. So if you're having insomnia, you are waking too much at night, or having issues, even falling asleep, check the medication list. There are medications that might cause insomnia, and one of them in the setting of Parkinson is the use of amantadine and selengilin. Selengilin is actually metabolized in amphetamine. So imagine you taking selengilin at 8 p.m. So it's basically taking amphetamine stimulant at 8 p.m. So not a good idea. So move the selengilin. Selengilin actually should be in the morning, and the second dose should be with lunch, 12 to 2 p.m. Okay. Amantadine is another one that it might cause insomnia. And that's sometimes I use it for fatigue, even though that there is no good evidence in the setting of Parkinson. Patient with MS, actually, there are some data in patient with MS and fatigue, but not good data in Parkinson. Now, if you, another reason for you to have a sleep fragmentation or waking up multiple times at night in the setting of Parkinson is you to have nocturnal motor symptoms, which means that the medication is getting out of your system. So your brain wake you up like this is how the brain work. Wake up. You need your levodopa, and that's why. Okay. So, and remember, when we sleep, we move, we go to the side, and we actually don't wake up, we move. But people with Parkinson, because they are rigid, they are stiff, it's difficult for them to mobilize on the bed, and that's why they wake up. Okay. And sometimes you wake up in the middle of the night and you have the shakiness, and then you cannot go back to sleep because, oh my God, this tremor. And because you are in the relaxed position. Remember that in Parkinson, the tremor is during resting. So there are some patients that they just concentrate in the tremor and they cannot sleep. So what you have to do is just to take an extra dose of levodopa to see what happens. Okay, and sometimes some patients, they have what we call the painful dystonia, right? I told you in prior slides about the off dystonia, the off phenomenon that the brain is telling you, give me my levodopa or I will squeeze you. Now, also rule out other sleep condition, specifically sleep apnea, right? Sleep apnea. You have sleep apnea, you stop breathing, apnea, stop breathing, you wake up. Again, you wake up, okay? RLS, restless leg syndrome, which can be seen in patients with Parkinson a lot, but not just Parkinson. We don't know if this is actually that is more common in patients with Parkinson, or it's just because you are giving a medication, levodopa, which might actually cause augmentation, increase the symptoms of RLS long term. So we are not sure about that, but you see that, and you need to diagnose RLS, because RLS, they have treatment, right? And this is one of the most common, actually the most common movement disorder is RLS. There is something that we call periodic limb movement. So patients start jerking, legs jerk, and you see that in patients with Parkinson. And also RBD, REM sleep behavior disorder. We need to rule out REM sleep behavior disorder. Anxiety, try it. If you have anxiety and you have depression, you might be affecting your sleep. So those patients wake up early in the morning, and they have a lot of sleep fragmentation as well. And what they need is just to treat the depression, and this get better. So trazodone is actually very effective for insomnia related specifically with depression. And so it's very, very good medication and very, very safe in the setting of Parkinson's disease. I use it. Mirtazapine is a medication which has some might cause sedation, and that's why we use it to help patients to sleep, but also increase the appetite. Increase the appetite. So something that, if it's some patient with Parkinson, especially a late stage, start decreasing, losing weight. So there's a medication that you might consider mirtazapine, and it has some, quote, anti-tremor property as well. There's some evidence that mirtazapine might help with some of the tremors. I clinically have not seen that, but it's documented. Nightmares, that's another reason. So people, you can have Parkinson, or with and without Parkinson, people have nightmares. So, and I'm not talking about here RVD, because nightmares can happen in REM stage, but also in another stage, which is a non-REM stage, specifically in N2. This is more details that you don't need to know, but so this is different. So patients are not acting out during sleep. They have a very bad dream, very bad dream. It's a nightmare. And so if you have, for example, we have data in patient with post-traumatic stress disorder, you use this medication, post-traumatic stress disorder, you have this medication, and it might help actually. It might help, we have evidence, but however, in the setting of Parkinson, you have to be careful because it might drop the blood pressure. This medication drop the blood pressure. We call that orthostatic hypotension. So the patient stand up and the blood pressure drop. Be careful with this medication in the setting of Parkinson's disease. But if you don't have those issues with blood pressure or orthostatic hypotension, and you actually have post-traumatic stress disorder, this is a medication to try. Sometimes I try melatonin, and there's some evidence that melatonin help, and sometimes actually might make the nightmares worse. So good to try. Now, if you ask me what is the evidence, what the Movement Disorder Society recommend, and this is the Movement Disorder Society group. This was published in 2019. So they recommend rotigotine, the patch. This is the Nupro patch, which help with the sleep quality and maintenance. Okay, this is what they recommend. I sometimes use it when the insurance allow me. So remember that many times we prescribe medications, and medications are approved for things, but we cannot use it because patient cannot afford it. And patients are not going to pay $300 for a medication. It's like paying a Mercedes-Benz for a medication. This is crazy, but this is what it is. It's just there are some medications that are very expensive. But this is what we recommend, especially especially in the setting of RLS. Imagine that this patient with Parkinson, they have RLS, they have periodic limb movements or wearing off at night. So that's a medication to use, especially you are a young patient. We are trying to avoid dopamine agonists. There are many side effects for dopamine agonists, but this is, if I'm going to use a dopamine agonist and the insurance cover, this is the one I will use, okay? Excessive daytime sleepiness, and this is the last part. This is a very common thing in Parkinson, very common. The most important thing is just to rule out secondary causes. And the first thing that you need to rule out in anybody having excessive daytime sleepiness with and without Parkinson is to have a sleep study. You need to rule out obstructive sleep apnea, because if you don't treat that, you are at risk of having many things. For example, you are at risk of having depression, anxiety, memory issues, stroke, atrial fibrillation, irritability, cognitive issues. I think I say memory. So it's highly associated with many things, and it's just easy to make the diagnosis. Easy. You just need to get the sleep study. Okay, get a sleep study, and make sure that you sleep. Because otherwise, if you don't sleep during the study, so they cannot detect the problem, and it might be a false negative test, right? Oh, we could not find sleep apnea. Well, because I didn't sleep. So that happened many times. Okay, so sometimes we need to modify the medication that we use to treat Parkinson's disease, because sometimes the medication that we use to treat Parkinson actually exacerbate daytime sleepiness. Sometimes when the patient are having significant peak dose drowsiness, peak dose, so you take the medication and 45 minutes or 30 minutes after the pill, patient becomes sleepy. So one thing that you can do is just to switch to the control release, okay? Control release. because it has less peak side effect. You can try that. The only problem with the CER is the absorption. It has some erratic absorption. So the potency would be like 65-70% of the regular carbidopa levodopa. The most common medication in the setting of Parkinson medication that we use to treat Parkinson symptoms that might cause excessive daytime sleepiness are this one here, which are the dopamine agonist. So this medication causes daytime sleepiness. So you might need to discontinue this type of medication, okay? Now, you can try selengilin, which is, remember I told you, is metabolized in amphetamine. That might make you more awake, right? You can try that. Otherwise, sometimes I try that and never work, but there is some evidence. The evidence is here. Modafinil, also, we have some evidence, and there are some patients that actually respond. I typically go and start with 100 and then go to 200. And the patient doesn't have any cardiac issues, any major thing, I go even to 400. So everything depends, and in the morning. And then this one actually, I have more evidence. No, I don't want to say evidence. I have better experience with Ritalin and patient with fatigue. But you need to reach sometimes doses of 15 or even a little bit more Ritalin. So the data is mixed, but in real life, remember, whatever you see in clinical trials is not the same thing that you see in real life. Sometimes it's different. I don't want to say sometimes, actually more frequent than not. But I see Ritalin working for those patients many times. And that's it. That's what I have today. Thank you very much. If you like this video, don't forget to subscribe to my channel. See you soon.